Hello, good evening, friends. Yesterday I was a little busy, so I could not take the class, but I had uploaded PCOS part 3. I hope you watched that and enjoyed that. Today I'm going to talk about a day-to-day topic, that is abnormal uterine bleeding. Almost 30% of the patients in gynae OPD are abnormal uterine bleeding patients. The old terminology for this was DUB, that is dysfunctional uterine bleeding, when I was a PG. But of late, you don't see this particular terminology in any textbook. In a way, DUB is hidden in this. I will talk about that little later. Also, there are a lot of changes which I'm going to talk about. This may be very basic for some of you, but considering that new postgraduates have joined and they need to know about this, and also some of the exam going PGs may need to know about the new changes that have happened. It may be a repetition, the initial part, but I think I have to do justice to all. So I'll be talking about them in little bit detail. I hope you tolerate that part. So AUB, when you say abnormal uterine bleeding, it's menstrual bleeding of abnormal quantity, duration, or schedule, or all the three. So quantity may be more or less, duration may be again more or less, and schedule may be, even though regular, it may be frequent, infrequent, and totally out of schedule. All come under AUB. It occurs in 1 in 3 women. As I said, almost 30% of the female population will have abnormal uterine bleeding, especially in the reproductive age group, that is from menarche to menopause, even sometimes after that. Concern is anemia. 21 to 67% of anemia in women can be due to AUB, and much more importantly, endometrial carcinoma, which is really preventable, and that's why we must understand this clearly and work towards that. The impact of AUB, if I have to say, there will be anxiety because of unscheduled bleeding, decreased work productivity if the bleeding is heavy, iron deficiency anemia, which already has been explained, discomfort if there is associated dysmenorrhea, negative impact on relationship with partners. Those many days, suppose the bleeding is for many days, those many days they won't be able to have sexual intercourse, and that may be impact on the relationship with partners. Also, the lady may not be participating properly in the household chores. Decreased quality of life in general. So that is the impact of AUB. It affects the women as well as it affects the family. Major impact on a woman's quality of life is the concern. Over 60% of women with heavy menstrual bleeding ended up having a hysterectomy within 5 years from the diagnosis, because they would have been fed up of the medical line of management or other conservative line of management, and they themselves may request for an hysterectomy. About 1/3 of hysterectomies for heavy menstrual bleeding result in removal of anatomically normal uterus. That is the tragedy. Even though there is no indication as such, maybe a fibroid or a carcinoma, endometrium, or other causes look like genuine indications for hysterectomy, but 1/3 of the hysterectomies probably are normal uterus. But when we say normal uterus, it has to be in inverted comma, because there is some functional problem which is not correctable. That's why women ask for hysterectomy. I don't want to talk about the gynecologist prescribing hysterectomy, but I'm only talking about women asking for hysterectomy. This is extremely important, the FIGO system, that 1 and modified version. This is the one which every PG should know. The old terminologies of menorrhagia, hypomenorrhea, or hypermenorrhea, polymenorrhea, oligomenorrhea. All these things have now changed. And this is very important for us to understand, and we should continue with that. And I have tried to simplify this also. I told you 3 items in menstruation. That is, one is frequency, duration, and amount. When we talk about frequency, what is normal and what is abnormal has to be clearly understood. Absent, that is no bleeding, is amenorrhea. Very easy. Frequent is less than 24 days. Earlier it was called less than 21 days, which was polymenorrhea. Now infrequent is more than 38 days. Earlier it was 35 days. And normal, earlier we used to say 28 days. Now it is equal to or more than 24 days to equal to or less than 38 days. So as you can see here, they have given us a range, and which is more realistic, because no woman will have cycles 1 in 28 days. It was a wrong notion that normal cycle is 28 days. It was easy for us to explain to the undergraduate students that it's a table of 7. That is 7 3 times is 21 is polymenorrhea, 7 4 times is 28 normal menstrual cycle, 7 5 times 35 is oligomenorrhea. But that never happens. This is more realistic according to me. So 38 is infrequent, not 35. 24 is frequent, not 21. This has to be understood clearly. Now coming to the duration, again, earlier we used to say 80 ml is normal. Who is going to sit and quantify that? Impossible. And you can't say 2 to 3 days, 4 days. So they have been quite generous. Normal is something equal to or less than 8 days. Because there are wide variety, and they have taken into consideration all that. Out of these 8 days, maybe only first 3 days or 4 days are heavy, but still some spotting will go on up to 8 days in some women, and that is normal. But if it is more than 8 days, then it is considered prolonged bleeding. Next is regularity. Normal or regular. Now here comes the little bit of a googly. That is, shortest to longest cycle variation is less than or equal to 7 to 9 days. The variation from the longest to the shortest. Let's say shortest bleeding, the cycle was 20 days, and the longest was, let's say, 27 days. So it is well within 7 days, 7 to 9 days. So it's normal or regular, fairly regular. When will you call it irregular? The shortest to longest cycle variation is equal to or more than 8 to 10 days. For example, I'll take the same example. The normal was 20 days. I mean, first one cycle was 20 days. Another cycle was 35 days. Now it is variation is more than 8 to 10 days. That's where it is called irregular. So less than 8. I'm trying to make everything about 8 or more than 8. So earlier was the table of 7. Now I'm trying to make it everything in terms of 8. Prolonged cycle means more than 8 days. Normal cycle means variation less than 8 days. And frequent cycle means 8 3s are 24, less than 24 days. And of course, I cannot go to 8 4s are 36, it is 38, but again, there is an 8, so 8 days. Then comes the volume or the flow. This is very, very difficult. There were many, many ways of explaining this. Number of pads used, you will go wrong, because some ladies may change the pads just if it is a little bit stained. And the weighing of the pads was the most difficult one. Whether the pad was fully soaked, half soaked, who is going to check all that? So they have made it so simple. That is light as per the patient's feeling, normal again as per the patient's feeling, heavy again as per the patient's feeling. So this volume is patient determined. I think that's the right thing to do. So this is the new thing, and we have to remember this. There is no escape from this. You can almost forget talking in terms of polymenorrhea, menorrhagia, and oligomenorrhea. Yes, menorrhagia meant heavy bleeding with a regular cycle. Polymenorrhea meant frequent cycles. Oligomenorrhea meant infrequent cycles. But these numbers, what we are now looking at, are more realistic. I think I agree with this. Then intermenstrual bleeding. Bleeding between cyclically regular onset of menses. See, this is very important. The onset of menses should be fairly regular. And in between, if you have bleeding, then it is called intermenstrual bleeding. So how do you document it? Is none means there is absolutely no intermenstrual bleeding. Random means it's not at a regular interval, I would say. Whereas cyclical, that means predictable. Every month she is having this intermenstrual bleeding. It could be either early cycle intermenstrual bleeding, or mid-cycle intermenstrual bleeding, or late cycle intermenstrual bleeding. Now, this is some sort of predictable. So whenever something is predictable, I want to clarify here. In fact, I told you in many other classes that the bleeding that occurs in women are mainly of two types. What are the two types of bleeding? One is menstrual bleeding. Other one is surface bleeding. What is the difference? Menstrual bleeding has some sort of predictability or a pattern, or it is because of a hormonal cycle, whether the cycle is normal or abnormal. Whereas the surface bleeding has no rhythm or rhyme or reason. Reason is there, but that is the cancer. So when the bleeding is surface bleeding, it is mostly cancerous type of bleeding, or maybe sometimes even in a infected prolapse and all, there will be some erratic bleeding. But otherwise, the surface bleeding has got no rhythm, no hormonal connection. So whenever there is predictability, it is still connected with the menstrual cycle. Whereas when it is unscheduled bleeding on progestin plus or minus estrogen, gonadal steroids, or birth control pills, rings and patches, injection, that is a different category, not applicable. That means not on gonadal steroid medication. Then probably it is a case to be evaluated for ruling out cancers. None, that is on gonadal steroid medication, but still she doesn't have any unscheduled bleeding. Probably the patient is taking steroids properly and the dosage is also proper. Whereas the last one is, it is present. We have to understand that probably the dosage is not adequate for her, or probably she is taking in an erratic way. So I hope this is very clear. They have spent a lot of time making this system, and it is wonderful. Acute versus chronic AUB. Acute means an episode of heavy bleeding that, in the opinion of the clinician, is of sufficient quantity to require immediate intervention to minimize or prevent further blood loss. Now here, as you can see, it is not patient's perception. It is the opinion of the clinician who thinks that it is sufficient in quantity to require immediate intervention to minimize or prevent further blood loss. That is acute. It's really heavy. Chronic has been present for majority of the preceding 6 months. 6 months, you see, usually what happens, the patient comes and says, I have got heavy bleeding. This may be the first episode actually. And it is sometimes wrong to judge that it is an AUB. This may be due to any reason, but it is acute, all right. But if you want to say that it is a proper AUB, which is a chronic AUB, this problem should have been there for last 6 months. Acute heavy menstrual bleeding may present in the context of existing chronic AUB, or can occur in the absence of such a background history. So this is something like acute on chronic. Like in obstetrics, we say acute on chronic fetal distress. There is a chronic hypoxia, but suddenly an event in the labor, that is maybe hyperactivity of the uterus, which will induce an acute fetal distress on a chronic distress, that is chronic hypoxia. So I hope this also is very important for us to understand. Now I come to FIGO system 2, the classification of the causes. Now, earlier we used to have our own type of classification, but this is much more of organized way of classifying. All of you know this. I think I should just skip this slide, but I will just make a quick mention, but again, for the sake of if there are any first year PGs. PALM, that is P for polyp, A for adenomyosis, L for leiomyoma, M for malignancy. And of course, hyperplasia is also. The other day, one of the PGs asked me privately in the WhatsApp that, sir, what to consider hyperplasia? Which hyperplasia? Obviously, it is atypical hyperplasia, which is more towards malignancy rather than simple hyperplasia. Now, the latest classification is simple hyperplasia, complex hyperplasia. Both can be with or without atypia. So it's not just hyperplasia, it has to be atypical hyperplasia according to me. Then coin, 1,000 rupee coin I put. C for coagulopathy, O for ovulatory dysfunction. This is the one which was called DUB in the past. And there we used to say ovulatory, anovulatory DUB. And then of course we used to have secondary DUB, which is due to causes outside the reproductive system like thyroids and other problems, secondary to something, and then iatrogenic DUB. Now, all those things have been beautifully now classified, reclassified, I should say. Ovulatory dysfunction means ovulatory, whether ovulation or anovulation, both come under this DUB. Then you have endometrial DUB, a separate entity they have called. Probably this includes the endometrial problems of maybe hyperplasia, which are benign, or sometimes it may be due to endometritis. You can also say not endometriosis, endometritis, infection. Unfortunately, as you can see here, there is no infection. Some people consider it as infection. It's not infection, it is iatrogenic, which was there in the old classification, also iatrogenic DUB, again, which could be due to insertion of copper T or OC pills and things like that. And finally, N for not yet classified. In fact, I had written a letter once in 2011 when it had come. Where is the infection here? Because whenever there was menorrhagia, if you ask any undergraduate student, the 3 causes of menorrhagia, they would straight away come up with, number 1 is, of course, the fibroids. Number 2, they would say endometriosis. And number 3 was always PID. I hope all of you agree with me. But PID is totally missing here in AUB. Probably it could be under endometrial, as I said, hyperplasia or infection or inflammation, endometritis, or it could be under not yet classified. Maybe after some time they will sit together and try to fit in where to put this PID. The term dysfunction uterine bleeding is discontinued. All of us know that. Ovulatory dysfunction was the one which was considered DUB in the past. The FIGO system 2 PALM-COEIN in pictures: polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory, endometrial, iatrogenic, and not otherwise classified. Now, there has been a revision after 2011 classification in 2018, which reclassified the nomenclatures in the menstruation. They reclassified this also, that is the PALM-COEIN system. What is that? P is yet to be subclassified. So they have just left it like P is polyp. They have not subclassified yet. But A, that is PALM adenomyosis, they refined this adenomyosis based on sonographic diagnostic criteria. Let us look at that. And this criteria goes by famous Musa criteria, right? That is ultrasound based. It could be asymmetrical myometrial thickness. Can you see this? The posterior myometrium is thicker than the anterior myometrium. That is one finding. It need not be, all of them need not be present in a single patient. Any one of them or a combination of them is also okay. B, myometrial cysts, as you can see, small cysts here. Also, the posterior myometrium is thicker than the anterior myometrium. Hypoechoic islands, these are small cysts, but these are like big islands. They have maintained this posterior wall thickness. That's the beauty of this artist. He has understood properly the briefing given to him by gynecologist. Fan-shaped shadowing. As you can see, this fan-shaped shadowing. This is because of adenomyotic lesions. Echogenic subendothelial lines and buds. As you can see here, you can see the extension into the endometrium. After all, the adenomyosis is a type of endometriosis, I should say. In general, endometriosis means the endometrium is outside the cavity. Now, outside the cavity can be in the myometrium or totally outside the uterus. When it is totally outside the uterus, it is called endometriosis. But when it is in the myometrium, it is called adenomyosis. Now, why should it come to myometrium? It has to leak from the endometrium. So that's how it is beautifully shown here, echogenic subendothelial lines or buds. Then you have translesional vascularity. Of course, whenever there is endometrium, it develops vascularity in and around it. That vascularity also can be seen either by throwing a Doppler, color Doppler, or even otherwise. Then irregular zonal junction. So this zone, endometrium, myometrium zone, is usually smooth, but if there is adenomyosis, it is irregular like that. And finally, H is interrupted zonal zones. As you can see here, in between there is no zonal junction at all. So this is probably where endometrium is merging with the myometrium. So any of these 8 characters will define whether it is adenomyosis or not. So nobody should have any doubt about it. Even by MRI, it will be the same findings. Then we'll go to L. Inclusion of type 3 as submucous. In detail, I have taken this in one of the classes. I will repeat this today, and I'm sure many PGs are going to be happy with this. And in fact, some of the PGs asked me for the picture of this. I have shared that picture also, but today I'm again talking about that. Inclusion of type 3 as submucous. I will tell for the new PGs what is type 1, type 2, and there is up to type 8. Distinction between type 0, 1, 6, and 7 based on the stalk diameter. When I show you the picture in the next slide, you will understand this. 2 and 3 based on lowest filling pressure. 5 and 4 based on distortion of serosa. Now, this all sounds like Latin and Greek to you. Now, let us look at the picture. Now it is very clear, isn't it? So 0, look at this 0. 0 means it is totally inside the cavity with this beautiful stalk there. So that is 0. The next one is 1. Most of it, more than 50% of it is in the cavity. Little bit is in the myometrium, no stalk as such. Then 2, of course, 5 also they have written because 5 is intramural. 1 which is going towards serosa, and here it is going towards endometrial cavity. So 2 is mostly in the myometrium, little bit in the cavity. Whereas 3, as you can see here, it is 100%, almost 100% in the myometria, but it is just touching the cavity or kissing the cavity. Now, this is the one which is now considered submucous. Now, why they have considered submucous is a question. They have probably considered this as submucous because it will have an impact same as submucous. It may not be because of its role in surgery or the way you do the surgery for this. Probably this cannot be removed unless you really go and keep on curating this myoma through a resectoscope. This is probably best tackled by a laparotomy and a sort of myomectomy type of a thing. But it is still subclassified or considered as submucous because it will have the same impact on the implantation as 0, 1, and 2. That's what I think. Then you have 4, which is clearly intramural. There's absolutely no doubt. It is neither near the cavity nor near the serous. Whereas 5 again, as you can see is here, mostly in the myometrium, little bit bulge on the serous. Whereas 6 is mostly subserous, little bit in the intramural. Whereas 7 is purely subserous, also with a stalk, pedunculated subserous fibroid. No doubt in that. Whereas 8 is, of course, other types. They have shown one here, that is a cervical type. I hope this much is clear. Now, once this is clear, I will come to the complicated part of it. This is a simple part of it. The 2018 revision is subclassification of this again. What is that? One, I have already told you. That is 3 and 1 and 2. How they are sub-classified is what we have to see. So 3 is included as submucous. That's what I would just now told you and explained to you why and all that. Now 0 and 1 is further subclassified. Similarly, 6 and 7 are further classified. How can you guess? Based on the stock. 0 has a good stock, 7 has a good stock, isn't it? So the distinction between types 0 and 1, 6 and 7, based on the stock diameter. Now this will definitely have an influence on the type of surgery you do. If it's a beautifully pedunculated, whether it is totally intracavitary or a totally subserous, you can just put a clamp on the peduncle and remove it. Easy operation. Whereas if it is 1, it is easier compared to 2, and if it is 6, it is easier compared to 5. Okay, but it is different from 0 and 7. That's the meaning of it. Then you have the differences between 2 and 3 based on the lowest filling pressure. 3 will have a almost 0 filling pressure, whereas 2 will definitely create a filling pressure. And finally, the difference between 4 and 5 is based on the distortion of the serosa. 4 hardly distorts the serosa, whereas 5 distorts the serosa. This is just to complicate the life of a postgraduate. You have no other choice. You have to learn this. Take a nice screenshot of this. So let us continue with COEIN. C no longer includes AUB associated with pharmacologic agents that impair blood coagulation, which are now included under AUB iatrogenic. And I think that's correct. They cannot put some drug-induced coagulopathy in C, because we have again another category called iatrogenic, where the drugs are going to cause the problem which are prescribed by the doctors. I think this is a intelligent move. No longer includes AUB associated with pharmacologic agents that impair blood coagulation, which are now included under AUB. I means iatrogenic. O, diagnostic threshold changes based on the revision of system 1. What is system 1? We told you the diagnostic changes, wherein you are talking about infrequent cycle, frequent cycle. Now the threshold is 38 days, 24 days, and the range that has been given for a normal cycle. Heavy bleeding means more than 8 days. Heavy flow means patient's feeling. All these things will now determine the diagnostic threshold of the ovulatory type of AUB. No longer includes ovulatory disorders associated with the drugs known or suspected to interfere with ovulation. It may be the patient is taking ovulatory inducing agents, or there are other drugs which are probably coming in the way of ovulation. So that is why those cases have to be excluded. Without any medication, if she has got ovulatory type of dysfunction, then only that is called ovulatory dysfunction. I hope this is clear. Further, iatrogenic now includes AUB associated with all iatrogenic processes, including use of pharmacological agents used for anticoagulation and those thought to interfere with ovulation. Whatever were excluded from C and O are included here. That means drugs that will cause coagulation problems, drugs that will come in the way of ovulation, they all are now under I. In addition to that, the usual what was there before, that is OC pills or some insertion of copper T, anything and everything will come under I now. N, that is the name of the category has been changed from not yet classified to not otherwise classified, as though they have done a great favor to us. Not yet classified, meaning now they are saying we have classified it. How they have classified it? As not otherwise classified. I mean, nothing great there. But probably this includes everything. There are so many things like probably AV malformation, infections, and there is something called isthmosele. There are so many things included under this, not otherwise classified. Don't call it not yet classified. So, not otherwise classified, as I said, there is a brief discussion of a potential new cause of AOB, so-called niche or isthmosele, following lower segment cesarean section. They didn't know how to put it. It's not adenomyosis, it's not scar endometriosis, it is nothing. So they are simply calling it niche or isthmosele. Fine. Chronic endometritis, that's what I told you, no? When we said infection was not included, I think like me, many people must have written to FIGO. So now they are saying infection comes or inflammation. Endometritis can be due to infection or also could be aseptic inflammation due to copper T. We all know that. So, but that can also cause heavy bleeding. Menorrhagia we used to call earlier, copper T induced menorrhagia. So that now comes under not otherwise classified. Arteriovenous malformation, I told you, there are cases now which will not respond to anything and everything what you do. In fact, we had a couple of cases in Manipal and we had to finally offer them, UAE, that is uterine artery embolization, that helped them. But after that, they conceived and again came back with the same problem. Finally, we had to do hysterectomy for them. There is no other choice. Myometrial hypertrophy. Now, this is neither fibroid nor anything, nor adenomyosis. It's just a myometrial hypertrophy giving rise to heavy bleeding maybe. That is coming under not otherwise classified. How do you do the notation of this? Like parity index. See, we say G2, P1, L1, A0 and all that. PGs are very fond of saying that G2, P1. And some examiners get irritated. What is G2, P1? They expect the student to say gravida 1, para 0, things like that. Anyway, so if an individual was suspected to have disorders of ovulation, a type 2 leiomyoma, and no other anomalies, how do you do the notation of this? AUB P0, that means no polyp. A0 means there is no adenomyosis. L1, because she has got a myoma there. Okay, L1. And M0 means no malignancy. C0 means no coagulation problem. O1, disorder of ovulation is also there, isn't it? Such a O1. E is endometrial issues are 0. I means iatrogenic 0 and no means 0. So this is how it should be written as the diagnosis. This is called the AUB index, not parity index, AUB index. Abbreviated description could be, if you don't want to write 0, 0, 0, 0, 0, if you simply write LSM, that means we know it is AUB, leiomyoma, maybe submucous leiomyoma, and then you can write it is ovulatory disorder. So here also, while taking the history, proper history, you can have a matrix like this, PALM-COEIN, yes or no, or question mark. Suppose the same patient, if I have to write it in a matrix way, L, it is yes, isn't it? So that's why I put it into here. Whereas all others are no. Maybe ovulation is also there. They should have put in here L. So this is probably the correct one in another case. Right? So I think I should continue with this characteristics and then I'll stop. I'll talk about the management maybe in the next class. Let us look at what are the characteristics. We talk about symptoms. Polyp will have intermenstrual bleeding, and infertility. Adenomyosis, heavy bleeding, and dysmenorrhea. Leiomyoma also heavy bleeding and dysmenorrhea. Both of them can have spasmodic dysmenorrhea, but mainly congestive dysmenorrhea. Malignancy, usually there will be postpartum bleeding or postmenopausal bleeding, and the bleeding is unscheduled because it is a surface bleeding. What about signs? Polyp, you can nicely see a polyp extruding out of the patulous os. Uterus may be normal. Adenomyosis, irregularly enlarged and firm uterus. Regularly enlarged firm uterus. Whereas fibroid is irregularly enlarged firm uterus. This is the typical undergraduate teaching. However, an odd case may be having a regular enlargement, especially if there is a single myoma, central myoma. Otherwise, typically, leiomyoma is irregularly enlarged uterus because they are multicentric in origin. Where in malignancy, it is enlarged uterus, but it is hard uterus. So that's how you differentiate you. See, malignancy is hard uterus, fibroid is firm uterus, pregnancy is soft uterus. Ultrasound-wise, polyp, you can see thick endometrium and echogenic mass with the sonosarcingography. Obscuring of endometrial junction, multiple hypoechoic halo zones. I have explained beautifully 8 pictures. Whereas in leiomyoma, you will see well-defined spherical hypoechoic areas. That is important, well-defined because of subcapsule, pseudocapsule. And spherical, they are round, they are centrifugally enlarging, hypoechoic areas. And in malignancy, again, thickened endometrial thickness and irregular endometrial line, that is malignancy. Other things now, for the COEIN part of it, symptom-wise coagulopathy, family history of bleeding, puberty, menorrhagia. For ovulatory dysfunction, amenorrhea or unpredictable and extreme heavy menstrual bleeding. For endometrial causes, predictable and cyclical menstrual bleeding, maybe heavy. Iatrogenic, unscheduled, varying amount depending upon the erratic way the patient is taking the tablets. Signs, coagulopathy, uterus is normal, no abnormality there. Easy bruisability can be seen in the other parts of the body, petechial hemorrhages, that will give you a clue. Whereas ovulatory dysfunction, signs of PCO may be there, oligomenorrhea may be there, signs of hyperandrogenism may be there, hirsutism, obesity, etc. In endometrial type, uterus is normal, endometrium may be abnormal. That will be found out only on microscopy.